Hello, and thank you so much for this invitation and opportunity to speak today as part of the Geriatric Medicine Board of Studies. And a special thank you to Dr. Lanny Ho, Fellow in Geriatric Medicine, as you know, in the Northern Training Alliance, for her support in making this happen. Sorry I can't be there in person, but I'm glad to be able to record this message instead. I'd like to start by acknowledging the first peoples and traditional owners of this land. I'm on Wurundjeri country, and to the people of the Kulin Nations, I pay my respects to elders past and present, and to all elders and Indigenous Victorians who've joined us today. I'd also like to remember and acknowledge all the aged care residents who've died through this pandemic, 810 of whom just in 2020 and many more since that time. Tragically, there are many ongoing deaths in Australia and globally. Hong Kong at the moment is going through an absolutely tragic and indeed preventable epidemic with many elderly people dying. And I'm thinking of their families as for Victorian families, the loved ones and all those who care for them. Today I want to discuss a number of themes, including lessons from the pandemic, our hospital response, clinician wellbeing, which is a topic close to my heart, leadership reflections, clinical engagement, innovation, recovery, and finally, because Lenny's asked me to, the role of geriatricians in public health that I think is important as well. So firstly, to lessons from the pandemic, no question that Victorians as a community have really faced unprecedented challenges, more so than other places in Australia and indeed many places in the world. But we did it by working together, and we've managed to avoid really the worst outcomes that many places globally have seen. We've successfully used public health measures to buy us time, and it really was to buy us time through a critical period whilst we scaled our health infrastructure and supported the rollout of one of Australia's biggest ever vaccination programs. And that's been the key to our success, being able to go through those really difficult and challenging times in order to roll out that most important of protections, and a tribute to all of the scientists and those behind that vaccination program. Of course, there have been huge challenges, mistakes, my mistakes, system mistakes, in Victoria, in Australia, and around the world. Not everything goes to plan, and it's a matter of deep regret for me, the decisions that I've made that haven't gone to plan, and some shame, for me personally, but for, I know, other clinicians, other public health physicians, and those in statutory positions here and around the world. Our hearts have been in the right places. We've wanted the best health and wellbeing outcomes across the board, but it's been a hugely challenging space to work in. And between the 100 decisions a day and the 16-hour days and the 7-day working weeks, there were always going to be things that didn't go well. But I do hope that it's recognised that we've all wanted to do our absolute utmost in this space, and we've all wanted the very best outcomes here and around the world. But it's important to get those lessons from the pandemic. It's important to deeply reflect on what it's taught us and to be different and better and wiser for it. But just to go through, the timeline from, let's face it, late December 2019, when we had reports of pneumonia of unknown etiology, causing a severe acute respiratory syndrome in Wuhan, now famous Wuhan in China. By early January 2020, and that's when it really came to my attention, there was a novel coronavirus identified. Victoria had a Chief Health Officer alert in that first week of January, and we were hoping to alert people to the possibility of this severe pneumonia and person-to-person transmission. Of course, it wasn't the first outbreak of a novel organism of concern in recent history. We had SARS in 2003. That was a real shot across the bow. H1N1, swine flu pandemic, but also the H5N1 bird flu that could have become a significant pandemic, and the H7N9 avian influenza that could also have become a pandemic but didn't. They're all lessons for us about just how fragile the space is between these zoonoses and potential pandemics that can kill so many people globally. What we now know is COVID-19 really far stretched our previous experiences. In the early days of the pandemic, one of Australia's advantages was our relative isolation, or our ability to close off from other countries, and that allowed us to implement border restrictions to try and manage that risk. In the end, that was a really important decision, I think, because we've had a 10 to 20-fold lower mortality cumulatively than many, many other countries, or than the global average has been. On the 10th of January, there were restrictions for people travelling from Wuhan, China. On the 1st of February, HPPC recommended that be applied to anyone who travelled from or transited through mainland China, and expanded to other countries in the following weeks, with all borders closed from late March 2020, a really momentous decision. As I say, in part enabled by our relative isolation, but other countries with big land borders, Vietnam, Laos, managed a similar approach and got to a zero community transmission despite the huge interconnectedness that they had in Southeast Asia. So we took advantage of our relative isolation, but it shouldn't be framed as only available to Australia. It was brave decision-making around the world, I think, that allowed for many, many countries to get to that zero transmission, and then a freer way of living through much of 2021. We did use that time for early preparation, focused on preparing the hospital system, reviewing our surge planning for the health sector, more than doubling our ICU capacity, and developing all that important early guidance for potential models of care. We did plan for many scenarios, disaster scaling that included the option of the exhibition centre being turned into a field hospital if required. There were thousands of ventilators procured, understanding that that's not the whole of the resourcing that you need. You need people, you need the spaces, you need the expertise and capability to be scaled up at the same time. We also did a huge scale up in PPE supply that was underdone pre-pandemic at a national level, and therefore across all jurisdictions, but lots of challenges there. Wuhan was a global production centre for PPE. Our efforts were obviously focused on testing and contact tracing, with Vigil developing tests, one of the first places in the world to, in fact, the second place in the world to isolate the virus after China. We really worked to be able to identify all of those cases, isolating those infectious individuals to be able to get over that transmission peak and get down to very low levels of transmission. And so the infrastructure was rapidly scaled up to support this. Our understanding of international and emerging Australian experience was that older people were going to be disproportionately impacted by COVID-19. Indeed, WHO reported through 2020 that it was a devastating toll on older people's lives in particular, and those in residential aged care disproportionately, massively disproportionately, a third to a half of all COVID deaths in Europe in 2020 were in residential aged care. By mid-2020, really when we would have hoped for no transmission, we had hotel quarantine transmission into the community and increasing cases of community transmission in Victoria, including in high-risk environments such as meat processing plants and other settings, including schools. And again, with the lessons of overseas, we knew that that would present a challenge in aged care settings, and indeed we saw a significant number of deaths. Aged care outbreaks are particularly complex and challenging, and there's variability in the ways that these services are structured, including their size, the clinical capacity there, the governance systems, and how each facility is managed. In some contexts, residential aged care services have significant difficulties in managing infectious disease outbreaks like COVID-19. The residents have complex care needs. There may be limited numbers of nursing staff, with many Cert 3 personal care workers doing a significant amount of the work involved and doing a phenomenal job, but with a different skill set to nursing staff and medical staff. And by the nature of the care required, staff needed to move from room to room to provide intimate care like showering. And residents, of course, might be living with dementia and have difficulties in understanding the directions that they were being given and the direction to isolate or to quarantine in their rooms. Very challenging. In the early days, PPE, as I say, supply was variable globally, nationally, and state policy on N95s was behind the times. It took a long time for the global policy to recognise aerosol transmission of N95. I think Victoria was a leader in many respects, but that was also too long in the grand scheme of things in terms of being able to meet the challenge of airborne transmission of COVID-19. And of course, there was limited expertise in the appropriate use of PPE. We hadn't used N95s in those settings up to that point in time. And as outbreaks increased across aged care, we had awful trade-offs in the provision of care and welfare, as there were significant constraints in visitors and in the movement of individuals and staff within and across aged care facilities. It is not straightforward to provide care when you've lost the ability of families and routine carers and loved ones to be able to provide that care. I know that during that time, many of you, your colleagues, nurses, the PCAs, and management staff worked absolutely tirelessly in responding to the needs of your residents and communities. Thank you so much for this. It can't be emphasised enough really how critical your responses were and how difficult it was for you. I know that it was tireless work. It was traumatising work, and many individuals saw things that you never wanted to see in your working life and never want to face again. But it is through that tireless work that we managed the mortality rates in Australia that have been 10 or 20 times higher in other places internationally. That is by virtue of your commitments and your ability to work within all of the constraints that came through public health orders as well, through a really, really challenging period of time. I hope that's never forgotten, and I hope you recognise what a central place you played in that response. In the hospital aged care and in-reach models, we had to change to respond to the really scaled up response to cases in residential aged care facilities. There was a lot of attention on our ICU capacity, of course, but there was another major piece of work in 2020 that was in aged care with geriatricians on the front line, through residential in-reach models, through the inpatient wards where care had to shift to aged care residents who are being looked after in acute care settings. And during this period, many of you scaled up your residential in-reach services far beyond the pre-pandemic levels that allowed provision of much-needed care in the residential sector that was under that really considerable distress. It was integral to our statewide response, and it did help us minimise those significant issues that unfolded overseas. I hope that in looking back, you do feel incredibly proud of the work you did in supporting that pandemic response. It was, as I say, absolutely integral to where we got to. and how we got to the other side. Now, it's not over yet, but there is much safety in our huge vaccine rollout. We still need our third doses and probably fourth and further doses, but that is a huge protection to our aged care residents and our elderly population more broadly. And we managed to get through that really critical phase to get to this huge shield of immunity, as it's been called, a wall of immunity that is protecting those most at risk, those most vulnerable. But it has not been easy to get there, that is for sure. Which brings me to the issue of clinician wellbeing. I hope you've taken some time, or you're taking some time now to look after yourselves. None of us at all have been unaffected through this pandemic. And we need to recognise that that's been in the personal challenges that we've had through lockdowns and in the professional pace and volume and obligations and duty of care through your work in your professional lives. But it is critically important to care for your own mental health and the well-being and that of your employees, your colleagues, your family members and your loved ones. I was supremely challenged through 2020. I've been open about sharing that because we need to tell our stories to be able to provide explicit permission to those around us to tell their stories, because it's in the telling of those stories that we can respond appropriately with love and compassion, but also the system and policy changes that allow for the appropriate care of employees. There are many, many lessons in workplace law, but also in the policy, in the operational response, and in the cultural shifts to put clinician wellbeing front and centre, because that is required for the operations to work appropriately and for carers to care for those that we are charged with caring for. And so on the one hand, we need to recognise the trauma, the PTSD, the ongoing mental health challenges, but we also need to change the system and take the lessons that we've been through over the last 2 years to make sure that clinician wellbeing is put front and centre in how our services and our statewide response recognises that into the future. If you're not familiar with Safer Care Victoria's Healthcare Worker Wellbeing Centre, please take some time to look at it. It is Safer Care's, best efforts to really put healthcare worker wellbeing in that central position and to try and do whatever we can as a department to support wellbeing now and into the future. My leadership reflections, well, part of it is about that, the fact that we're all just human beings in these most challenging of circumstances. I had my frailties and foibles and errors and fundamental failings. But the mark of a leader, I hope, is in reflecting on that properly, deeply, not with that immediate defensive mindset or closed mindset, but with a genuinely open mindset to say, yes, sure, there are haters and trolls online who will attack you because they just want to see the response. There are those who support you, sometimes ideologically or politically, without really reflecting on what you've done well or haven't done well. But in between, there are genuine commentaries that you need to take on board and that you need to deeply reflect on and try and change your approach, your understanding, your positions on things in order to be the best leader that you can be. And so my core leadership reflection is that we're all just trying to do our best through trying circumstances, but that the best that we can do is to take all of the wisdom around us, our peers, our supervisors, our huge teams, the 2,500 people who worked in the COVID-19 division who supported me, as a hugely valuable resource, and then more broadly to the clinical workforce sector, geriatricians, many others in public health, in infectious disease, in paediatrics, in primary care, across the board, to hear those critiques, to hear those ideas and innovations and deep reflections that many individuals have gone through, and take on board in order to be the best leader that you can be in representing those views, and in, yes, setting aside some commentary that isn't helpful or is really off-centre and wrong, but also to hear a lot of other really deeply worthwhile views that you need to incorporate to be in the best position to support that vision that you set for yourself, the health and wellbeing of Victorians, of Australians, of the global community in the public health response. And clinical engagement has been key to that. In 2020, there were many clinicians from the health sector that came into the department to support the COVID-19 response. I personally benefited from clinicians who came in and directly assisted me, most notably Prof. Alan Cheng, what an absolute star in the deputy role, and the same for Prof. Ben Cowie, who continues to support me, gives me my 1 day off a week on a Thursday, both being deputies to me for much of this time, and really important infectious disease reflections and that liaison with the clinician workforce, really critical for me. I'd also like to acknowledge the Victorian Aged Care Response Centre, established by the Victorian Department of Health, the Commonwealth and clinicians. That became a key part of getting on top of the challenges, having those conversations come together, troubleshooting all of those difficult issues, because let's face it, aged care sits in this really tricky space, locally registered facilities, Commonwealth funded, Commonwealth accreditation and quality and safety oversight, but with the state taking responsibility for outbreaks and infectious diseases. It is not an easy system to come together seamlessly. It does not come together seamlessly. You need all of those integrated, coordinated conversations to try and make that really complex system work as best as possible. And Safer Care Victoria played its role in tapping into its clinical networks to provide rapid advice from frontline clinicians. Really important lesson for me to hear those geriatrician voices and other clinical voices in informing our response. And there were over 250 clinicians who took part in working groups in our health service response. And they established systems for monitoring and oversight of hospital data, provided in almost real time early quality and safety signals, and made policy recommendations back to government. Really important early structures to prepare us for the subsequent challenges that we had. One of those innovations was the COVID positive pathways, a really successful innovation in my view, in the way that we provided a cascade of care from notification right through to home care and acute care. And it's a really great example of that innovative development that was informed by clinicians' voices. And, you know, as we saw the number of patients diagnosed increase significantly through the last 2 years, we knew that there would be follow-on pressures in hospital bed capacity. And so having a large proportion of our COVID-19 patients managed safely at home has been a really important innovation to have a proportionate response. We don't need everyone to be in acute care in order to have best and most appropriate care provided to them. It's been safe and timely in the Victorian context. Pulse oximetry monitoring being part of that, the development of a learning health network, bringing clinicians, consumers and quality improvement specialists together to enhance patient outcomes, and facilitating the decision making and data sharing and evidence to bring those improvements. There have been locally developed technology solutions like COVID Monitor that have been scaled across health services in promoting greater partnerships and networks in primary care. And almost finally to recovery. Well, this is going to be a long tail, really ongoing for years to come. We have shown our ability to be agile and respond to new challenges, but there have been fundamental changes and challenges to all Victorians that will mean that we've got a legacy of harm and need for recovery for years to come. You are the strong voices and advocates for older Victorians. There are other issues like elder abuse and other forms of discrimination that will continue to impact older Victorians who are often, less than appropriately visible in public debates. And while there have been some changes, there are system-level issues like the integration of those complex levels of government that I've spoken about, that the Royal Commission has highlighted and that will continue to impact older people through the remainder of the pandemic and in years to come. There are continuing mental health effects and disruptions to life that have occurred through the last 2 years that need to be managed for years to come. So we all need to continue to be vigilant in engaging with patients on what their needs are and informing state-level policy settings to inform the recovery. These will be felt for a long time. The fact that people's usual activities and usual resources for care were not available to them for much of the last 2 years has meant that there have been huge impacts, delayed care, changes to people's routines and their support networks. And that's, of course, affected their functional capacity and their psychological well-being. But it's in the, for example, the multidisciplinary comprehensive geriatric assessments that you will understand some of those issues and to be able to incorporate in a coordinated or integrated plan for treatment and for long-term follow-up. That will need to consider also the long-term impacts of long COVID that we know have multi-system effects and that still need a lot of elucidation in terms of exactly what kind of long-term outcomes they'll have. The geriatric expertise is still probably overly focused in metropolitan areas and can be concentrated overly in hospitals. And so part of our challenge going forward is how we improve access across the state to specialist geriatric services. We need to think about how the partnerships with primary care need to mature in that regard. We know that telehealth can really impact how we reach people. I hope it's an embedded part, I'm sure it will be, an embedded part of care provision going forwards and a way to reach some of those most at-risk individuals who have been held back by the inability to access care because of their remoteness. And so the blended models where telehealth is a genuine component of care is a real positive going forward. And I know it'll be part of your approach into the future. The innovations in outreach models such as Ambulance Victoria's pilot community paramedic model is one of those important innovations, with the paramedic acting as an intermediary between the patient, primary care and hospital care for older people. And so finally, to the role of geriatricians in public health, we're aware people haven't sought screening or other preventive activities during the pandemic. This needs to be reinforced, re-prosecuted across the elderly cohort in particular. As we get back to more business as usual or something like that, we need to really promote those positive behaviours, including seeking vaccination, and the elderly need their pneumococcal vaccine, their shingles vaccine, and of course Fluvax that will protect against the not insignificant impact of flu every year. It's kind of been forgotten in the last 2 years. It'll come back with a vengeance, and estimates are 750 Victorians die every year. So we need to really reinforce that going forward. Geriatricians, of course, will help aged care facilities navigate the pandemic orders going forward, such as visitor restrictions. They are much lighter now, and often the constraints have gone beyond the orders in terms of their restrictiveness. So part of it is trying to support a cultural shift, not to lock down. We will support that in terms of being really clear in our policy response that the strictness of lockdowns do not need to be the same as they were in 2020. They can really be limited to the isolation of cases and the quarantine just of those immediate close contacts. There'll be challenges of multi-drug resistant organisms going forward. We know that they can amplify in aged care facilities, and so antimicrobial stewardship and management of things like CPE, superbugs, will be important in aged care facilities. And there'll be the challenges, the existential health challenges of climate change, extreme heat, poor air quality from bushfires, but even floods and droughts disproportionately affect older people. And so important to, consider just how at risk the elderly are in some of these ongoing, very substantial challenges to our health and wellbeing. And just in closing, Dr. Ho's asked me to reflect on the future role of geriatric medicine in similar challenges to what we've been over the last 2 years. Firstly, I hope we never have a similar situation to what we've been through in the last 2 years. But the key thing for me is that as clinicians, you've been a wonderful resource to the public health response. Your voices and your specific efforts in joining the pandemic response have been so valuable. I really hope, and thank you for that generous support to our statewide efforts, I really hope that you continue to have strong engagement and a real voice at the table going forward. You are uniquely positioned, of course, to be an advocate for older people, but to genuinely inform us public health folk about what the needs are for individuals and what that means for the cohort of elderly people overall. So the population health considerations with the filter, the frame of older Victorians being how we understand the issues, the needs, the things that we need to do from a policy and response perspective. Thanks again for this opportunity to speak today. My thanks are small. There are so many people I know in the department and indeed across the Victorian community who would love to thank you. And so let me be a voice to represent those thanks as well for all of the work that you've done over the last 2+ years. And I wish you so well in your geriatric medicine careers going forward. Thanks again for this opportunity, and a wonderful opportunity for me to speak to you all today. Good on you.